So there's been a lot of work done looking at the preclinical mechanisms of action because we clinicians had noticed that Eribulin really was highly non-cross resistant in patients that we knew that we could not get control of this significant liver disease with any other agents. When Eribulin first came out, we were like, whoa, this is really different because you'd have this diffusely infiltrative disease because the real proliferative disease tends to be more nodules, but you'll get this diffusely infiltrative disease. We didn't have anything to really stop that, and Eribulin can work very, very quickly. So the question was why? What was the extra biology going on there? And some very interesting observations have come out and have been published now, and one of them is around angiogenesis, because it almost looked like maybe the blood supply of the cancer was being very rapidly taken away from the cancers, is perhaps why it responded so quickly. And it turns out in preclinical models that, in fact, the Eribulin does have a strong anti-angiogenic effect, basically. And it can help remodel this vasculature and make it more normal, less leaky and less tortuous, and can deliver higher levels of oxygen, higher oxygen saturation in the tumor following Eribulin therapy, which is really quite interesting. Mechanism-wise, it actually decreases levels of TGF-beta, transforming growth factor beta, is a highly pro-angiogenic substance in breast cancer. It decreases that, and so it's stopping this neovascularization, which is a very haphazard way of making microtubules that basically delivers very, very poor oxygen because they're very leaky and the blood is leaking out and making the cancer more and more dense and difficult to penetrate. And the Eribulin normalizes the vasculature by decreasing this neoangiogenic substance, TGF-beta, along with other mechanisms. So there is this interesting vascular remodeling with increase of oxygen saturation. And that's good because it's less wounding to the cells. They're less metastatic when they have oxygenation, and they don't have to upregulate these survival programs quite so much. And it may be that it helps with chemosensitization. I don't think we know that for sure, but it may be that it's helping. Certainly, though, with more drug delivery, with some normalization of the vasculature, you're getting more oxygen in there, you're also getting more chemotherapy in there to the tumor as well.
To be honest, even though a lot of time and energy is spent in the laboratory trying to understand mechanistically how our therapeutics work in cancer, at the end of the day, when the exam room door is closed and you're with your patient and perhaps their family, I'm really concerned about getting responses. And the mechanisms, they are secondary in that moment. And I just want treatment that's going to be effective and well tolerated and safe for my patients. And that's the overarching consideration at the end of the day. And that's what's most important and most impactful for patient care, is how are the patients going to respond and how are they going to tolerate the therapy. And so that's really a critical decision point when deciding what type of treatment to use next. It's really how are they going to respond to it, how well are they going to tolerate it, do they have comorbidities that might have particular problems that need to be acted upon. So at the end of the day, the mechanisms, while interesting, they take a back seat to really the more humanistic concerns of just wanting your patients to get better. I think if we looked very closely at other classes of chemotherapeutics, that we might see impacts on vascular remodeling. That's been shown with other chemotherapeutics already in the literature. For example, the taxanes have some of those properties. EMT also, there are other cytotoxic classes that can impact these cellular processes. So it's probably not restricted to just one class of chemotherapeutic, but it's certainly not a principle of every one of them either. So I think it bears a closer look in the laboratory to take a look at these different types of properties and maybe revisit them. And now that we understand some of these pathways and the biology behind some of these pathways, maybe there will be more therapeutic opportunities and new targets that can be identified through such studies.
With regard to angiogenesis, and other agents besides Eribulin that may have an anti-angiogenic effect, There's been a lot of work with paclitaxel that I'm aware of. Dr. George Sledge and others did a lot of work looking at the anti-angiogenic effects of paclitaxel. And indeed, paclitaxel does inhibit angiogenesis and some of the migration and assembly of the endothelial cells as they need to make new vasculature. So it's not unique to eribulin. And I'm not aware, for example, of ixabebolone or vinorelbine, other microtubule targeted agents, that they've looked at those questions preclinically. But certainly the paclitaxel, I'm sure, has anti-angiogenic effects.